through the nature of what I do, I see a lot of neck and back pain. I see a lot of motor vehicle injuries. I see a lot of legitimate legal cases involving chronic pain, neck and back pain from core injuries. I have a particular interest in athletic injuries because in high school I played football and soccer competitively, so I'm familiar with a lot of these injuries and scenarios, and I've seen some serious injuries on the field. So I'd like to address the coaches and trainers on things to recognize. I want to go over the 2013 Louisiana Concussion Act, why that was put in place, and give you a little bit of guidance on what to do when you suspect a concussion on the field. What can the athlete and the family expect in the days and weeks to come? Also, I'm going to touch on a little bit on the chronic pain aspects, but I'd like to address the therapists as well. The ongoing back or neck issues, rehabilitation, not just from a preventative standpoint, but also for a performance standpoint, and some different exercises and things to incorporate in your warm-ups and even your heavy lifting for your athletes. This is a injury of a football. This is a picture of a football player being carried off the field. I'm going to address some what to do for the trainers when they see an injury on the field and how to properly remove the player. This is probably a picture of not a good way just to drag them off the field. So there's better ways of doing it we can talk about. I want to talk about the concussion, the serious neurological injuries. I'm going to first talk about the spine, then I'd like to move to the concussions. But a lot of coaches or athletes have seen or heard the term spinal cord concussion or a zinger. These are different terms, usually refer to a short-term loss of sensory function or motor function. In my experience as a pain physician, I talk to a lot of patients who are involved in pretty serious high-speed motor vehicle injuries. And a lot of them will tell me, especially the higher speed ones, is they couldn't move. They thought they were paralyzed. And suddenly, a lot of their symptoms came back. It's a very scary sensation, but most of the time it's transient. But there are some certain things to look out for. The 2013 Louisiana Concussion Act didn't really address the spinal cord concussions, but the mechanism is the same. And I would go a little further and say that if an athlete has had a serious loss of motor or sensory function, reported couldn't move an extremity. I just lost some mic power, so I'll talk a little higher. But if you have an athlete that did lose some motor function, I would say to have that evaluated by a medical professional, because it could develop into a more serious issue. We saw Dr. Walker, the quarterback, he gave his talk, and the MRI that he showed, he was a walking, talking miracle. Those injuries are on the cusp of being a complete neurologic injury. And he's an example where the coaches did push him to go back in the game. It could have had a lot worse of an outcome. But these are very common. 1 in 7 in 10,000 football players do report. They usually resolve 10 minutes to 48 hours. I would say immobilize it, treat it like a serious injury until proven otherwise. What is the mechanism of these zingers, these temporary paralysis? Let's see if I can get this pointer working. Since I don't have a mic, I can walk around a little bit, but this is a vertebral body. It's a very basic picture, but there's a ligament here that was fractured, and this is what we call a kissing spine, where the vertebral bodies are almost touching. And what it does, it narrows the interspinous distance between the vertebral body and the posterior elements, the spinous process, and the lamina, causing compression there. It can be relieved with flexion. That's why I believe a lot of these patients are walking, talking miracles, because there are positional adjustments that do relieve it, but still they're impending serious issues. It can progress. Once this anterior spinous ligament is lost, it can progress, and this vertebral body can retrolesthese into the spinal canal, causing permanent nerve injury and spinal cord injury. Some other peripheral nerve injuries, Stinger syndrome. It's not so much a spinal cord, but a brachial plexus injury. When the neck is turned to the opposite side and the shoulder is compressed. You can see right here in this illustration, the neck is being flexed laterally and the shoulder is being pulled back, pulling on the brachial plexus. Had a patient who came to my office with neck pain, and we did an MRI. We didn't see any disc bulge or herniation. We did some treatment, some nerve blocks, some nerve ablation. She did well, but she still had a lot of shoulder injury and pain. Had a negative MRI, so we ended up doing a nerve conduction study and found that she had a brachial plexus injury. That was something that that can last a long time. Usually, over the course of time, can get better, but may involve even surgical repair. So when all else fails, you might have to get an EMG, or if an athlete has continual tingling, numbness, pain in that extremity, negative MRI, look further, get further neurological workup. This talks a little bit about some of the signs and symptoms are usually unilateral versus a spinal cord injury. You might see bilateral numbness or altered sensations, can last anywhere from 24 to 48 hours, or if there's long-term damage, can be up to 2 years or longer to resolve. I would still, if you suspect these injuries, have it worked up by a medical professional or someone trained in spinal cord injuries. Now, other serious, the herniated disc. Everyone's heard of a pinched nerve or a ruptured disc. This could happen at any age. I have a picture on the next slide, but ligamentous fractures. I've kind of talked about the anterior longitudinal ligament or the facet ligament, fractures along the pars vertebral body. That could set you up for a very serious neurological injury in the days or weeks to come. They should not go back, obviously, to competition if anything is suspected. Benign spinal injuries, a spinous process, a transverse process fracture, pretty much that's almost a reflex type 1 decision. You say, okay, go back. You're not having pain. That's all it is a spinous process, transverse fracture. So not all spinal injuries are life-threatening, but that's a rare exception. This is a picture of a herniated disc where this disc material, a soft material, comes outside and causes nerve compression. Now this is almost like an example we saw earlier. This is retrolesthesis, and usually this involves some sort of facet joint right here, fracture, causing complete retrolesthesis of this vertebral body, again setting up for permanent neurological injury. I don't know if this guy's paralyzed or not, but if he's not, it's another miracle. This is the anterior vertebral ligament right here. Once this fractures, the spine becomes unstable. You can have fractures in the disc as well. These are the posterior interspinous ligaments, usually a little more benign, but can cause excess flexion of the neck and spine, which can cause other problems. Now, removing equipment, you recognize a nerve injury or a serious situation on the field. Maybe it's a concussion or some sort of neck injury. The patient or the athlete is complaining of pain. How do you get them off the field? Well, almost treat that like a medical situation. Anesthesiologists or first responders are well trained on how to immobilize the neck. And so this next slide, I have it really just takes help. Someone has to immobilize the neck. Other people have to take the torso to get them on the board or the gurney or however you're going to transport them off the field. The first thing, obviously, assess. If he's not responding, airway, breathing, if the athlete's not responding, then that would usually be a situation where you would want to immobilize and carefully transport off the field. Here's an example where you have one, use a medical professional. If you have a team doctor, have them control the neck. Your trainer or other assistants can one at the feet, the hip, the chest. Roll them over, keeping this cervical spine intact. We recommend if there's a serious injury, suspected nerve damage, try not to move the equipment. You don't need to rush to remove the helmet. It's a reflex to try to make the athlete more comfortable, get this stuff off, but that could worsen the injury. If you can, if some helmets have the ability to take off this face mask, do that. If the athlete's having trouble breathing, it's a more serious situation, a jaw thrust to open up the airway. Now, if this is a spinal injury, when can the athlete go back? Well, obviously have it evaluated, him or her evaluated by a medical professional first, but here's general consensus or guidelines. No contraindications, 2 or less stingers, that's more the peripheral tingling, burning in the hands. Spinous process, transverse process fracture, like I mentioned earlier. Or what if they had surgery? One level, a cervical spine, we call it an ACDF. It's a little plate on the front of the neck. Usually rare to have this sort of surgery in a young athlete, but it can occur. One level, I would get permission from the spine surgeon, but usually if it's a one level asymptomatic, past the healing process, it's usually indicated. Relative contraindications, again, we're talking about that central transient quadriplegia, where there's loss of sensory motor function. You might want to, if it's one or more of these, you might want to have an MRI, because why does that keep recurring? It could be a congenital spinal stenosis. And there are guidelines, some cutoff values where you would recommend that athlete to refrain from competitive play. Other surgical, the cervical spine, a posterior fixation, not just the ACDF, getting a little more technical, but these probably a good relative contraindication. Absolute contraindications, multiple level fusions in the back of the neck, or any evidence of ongoing sensory abnormalities. Now, this Concussion Act, 2013, this act had to be made because a lot of coaches, as we heard earlier, wanted to push their players back in the game. It's just a ringer. He just got his bell ringed. Oh, what's the big deal? Boxers have it all the time. What's the worst case? Oh, they're going to get Alzheimer's. They're going to be Muhammad Ali when they're 70 years old. That's not the case. There's a difference with young athletes. It could be a lot more serious than just these long-term chronic traumatic encephalopathy issues. It's called a second incident syndrome. This is where the brain is trying to protect itself, and we don't know why it's more common in young athletes to have the second incident syndrome, but this is where it's a sudden death within minutes. The brain swells up, herniates, that second concussion, and just the swelling is so intense, it just pushes the brain contents down the spinal cord. You lose, the brainstem loses function, breathing, heart rate, circulation. It's rare. I'd still debate it, what's the cause. We believe it's more common in young athletes, but the brain is trying to recover from the first concussion. There is cerebral vasoconstriction, where the blood vessels clamp down to prevent a lot of blood flow, which could cause further injury. There's a lot of potassium leaks. The brain is in a hypermetabolic state trying to recover this ion balance. So the second injury occurs, and then the brain can no longer compensate, and it's a little bit of swelling. There's no compliance left in the brain, and it just reaches the end, and it's sudden death. There's been more studies on this. I was informed of a recent one past this study, but a recent one in California where they took monitors on young athletes in competitive 5A football, and they measured the impact of the head injuries, the force, and they did subsequent MRIs, and there were signs of micro bleeding within the brain. There's another study of 18 athletes who had CT scans, evidence of subdural hematomas. A CT scan is a little less sensitive than MRI, so even atraumatic or just concussion, first concussions, they did CT scans and there was evidence of bleeding even on a CT scan. Or this is after the second injury. So this is a little bit what I talk about. The second concussion, complete loss of ability to further prevent any swelling, can lead to death in 5 minutes. Again, occurs more common in adolescents and children. Now there's also the long-term consequences, the Muhammad Ali's or the vets coming back from Iraq and Afghanistan, a roadside bomb where they weren't necessarily directly injured, but just the impact caused a concussion. Well, we're seeing a lot of depression, personality changes, altered sensation, and so we're seeing this a lot with these roadside bombs and returning vets. This is Louisiana Concussion Act. What does it mean? I'm not necessarily saying they're going to go arrest the coach on the field if he puts a player back. It's a little hard to enforce, but it does mandate that coaches and officials be educated on recognizing signs and symptoms of a concussion, which I'll briefly discuss. It mandates that coaches and officials remove that athlete if there's any signs or symptoms of a concussion. And the athlete cannot return back to play without a physician's evaluation and clearance. The return to play, usually it's over a 5-day period. So that athlete and that coach will have to expect, you're going to have to not rush to put this player back. It's going to be at least a week. It's a stage-wise progression where the athlete, if they're asymptomatic, start with, usually there's academics, go back to classroom, instruct the teachers, want to know if there's any changes in performance or attention. Go back to schoolwork, light exercises, mainly aerobic. Go back then the next day after they're cleared, go back to running, agilities. And before they go back to putting on equipment, but non-contact, but before they go back to contact, a physician has to clear them. Just an evaluation, going over the signs and symptoms, and then go back to full contact sports, then they can return to play. This is a form, this is by the LHSAA. I just kind of cut and copied it from their website, but basically it's a check-off list, those 5 steps or whatever that I showed you. It's initial, I don't know if these are a coach or a trainer or something, but before they go back to full contact, the physician has to sign off on that. Signs and symptoms, this is from the CDC. Basically, it's just cognitive changes, their ability to focus, perform academically. One of the first questions you ask on the sideline if you suspect a concussion is, what was your last play? What's the score? If they can't remember the last play, they don't know who they're playing, just stuff that they should be situationally aware of, that's a sign of concussion. You can also ask them the 3-question test, apple, penny, table. Say, remember those, 5 minutes later I'm going to ask you. I mean, granted, high school athletes, you have to tell them or they won't remember, to remember, but that is one of the most missed answers when you're doing a psychological evaluation, so there is some leeway you have to give with that. But other things besides cognitive, behavior of the days and weeks, personality changes, any sensory impairment, noise, smells. I've seen this on the football field. I've seen big athletes. It's not the small guys who are getting their heads wrung because they're playing with big athletes. The bigger athletes, I remember seeing it immediately on the sideline, grabbing the helmet and seeing things. I've seen it happen later on the bus ride back from the game where the athlete just spontaneously talks crazy and talking about the game and going back in the game, so it can have a delayed effect. Now, that's the immediate implications. We've kind of talked about severe injuries of the spinal cord and severe implications of concussions. Kind of what I deal with on a more day-to-day basis is the chronic issues, the lower back pain, and to your surprise, I do see a lot of this. It's not gross herniation, the spine is stable, but it's just a little deterioration and a little more back pain than usual for the age. I have, on very select occasions, done epidural steroid shots for young athletes in high school. I don't like to do that, but usually it's more in conjunction with a physical therapist to get them to that level where they can go to physical therapy, because I believe that therapy is the long-term solution, especially in the younger population. These are hyper-intense signal changes. Are really, really hard to tell, but a little dot right here is the inner nucleus coming out, extruding out to that outer vertebral level. So what do you do for the chronic lower back issues if a degenerative disc or in that case? Well, the physical therapist can tell you a lot about core muscle strength and training, what that implies. Well, the core muscles are the abdominals and the back. Their function is to keep the spine still, to prevent it from moving. It's a safety mechanism, but it's also performance ability. And I'm going to talk a little bit more about that. My job as a role of chronic pain physician, I talk to more older population, talk about the core, how to prevent and move and posture and things like that to prevent further twisting of the spine and flexion on these discs. But it's really a performance. These muscles, we'll talk a little bit about how you can introduce workout routines, warm-up routines to enhance performance. The function, stability, posture, endurance. A lot of athletes, especially the line or a linebacker or a tailback, a lot of impact. Well, the coach always told us, you want to deliver the hit, not be the shock absorber for it. If your spine is flexed, if you don't have a strong core muscle, you're going to absorb that hit. You want to deliver that hit. So a strong core muscle is imperative for performance. This is basically the cartoon of a bodybuilder. You always see the big torso, the arms, and the emphasis on the small feet. Who cares about the feet? In reality, that's kind of true. I mean, I remember playing football with an athlete that almost looked like this. Huge, chiseled upper body core. We made fun of him because his legs are small. We call them chicken legs. But boy, could he hit. I mean, would just light your belt. He ended up going to college. Wasn't big, 5'9", maybe 5'10". And our coach the next year sent us, we watched a video of him laying a hit on kickoff and just leveling some big guy. He had a strong core, so it's very important for performance. These are the core muscles, the abdominal, the oblique muscles, external oblique, rectus abdominis, is a transverse abdominis. So you got the abdominal muscles, then you got your back muscles, all these small little muscles along the back. Just kind of a quick picture. One of the big authors with spine prevention and performance is Stuart McGill, PhD. He's a Canadian doctor, but has performed a lot of research. His analogy is harder to push a 5-ounce rope than it is to push a 300-pound rock. So if you don't have this abdominal core muscle strong, the back's just going to flex, and then you lose a lot of energy. Conservation of energy is a scientific term. Energy is not lost, it's just transferred to one form or the other. Going back to performance, you want to transfer your energy, not lose it to the back that's twisting and not flexible. With the hips, each stride you take, when the hips extend, it propels the body. If it has anything solid to propulse itself, then you're going to lose energy. There's a bunch of interesting animal studies that I found. I looked at the cheetah. The cheetah is a very high-performing predator animal. What makes it so fast? What makes them such a superior predator? Of course, the speed. That's undeniable. But two big research studies that I've seen is that one of them where the scientists have just watched the cheetah in the chase and recorded it and recorded these animals. And most of the hunts have done at 30 miles an hour. The cheetah can perform at 65 miles an hour. It's the cheetah's agility to turn and cut and make corners. For an athlete, the core muscles is a requirement. We use those core muscles to do those tasks. Another interesting study with cheetahs, they looked at an in vivo, in the lab study, where they took muscles from the cheetah's back and muscles from a rabbit, and they stimulated them. They measured how fast they contract in the force. The rabbit muscles are actually better performers, and that led them against their hypothesis that the cheetah's ability is superior locomotor performance depends on other aspects of the design, not just the superior muscle fibers. It all goes, and they've further analyzed these cheetahs, and they can make a sharper turn, 50-degree turn to the ground, where a motorcycle, a 45-degree angle. This is an example of a motorcycle making a sharp turn, but this cheetah can make a sharper turn because I don't know about animal core abdominal muscles, but we know in the human that these abdominal muscles are required. I had a good slide where there's force being pushed right here. There's two vectors going this way, and another vector going here. So in order to support the body, a longer, taller human, all that force coming down, these abdominal core muscles have to keep that trunk in line. And that's what makes a superior athlete. So what are some of the exercises you can do with your athletes to enhance this? You want to be careful about the spine. So I have some exercises, some fundamental stuff I teach my patients, older patients, on how to exercise the core muscles, and then more advanced with weights, core strengthening. This is Stuart McGill working with an athlete. He does not recommend doing any curls or crunches. He recommends isometric exercises where it's just holding that abdominal posture. Or this is another exercise. You take a ball and it's called stir the pot. Just go around and around with your arms, and the back's not moving. This is called the side bridge. Works on the abdominal obliques, keeping these firm and exercising. This hand is coming across to the opposite shoulder, adding a little weight to challenge. The bird dog, this hand is kind of just going a circular motion. A good physical therapist can tell you a little more about these exercises, but as far as a good workup routine, this is good to incorporate. More advanced trainings, these are working on asymmetric balance exercises, a heavier weight, a dumbbell, different various variations of these exercises, but working again on these abdominal obliques for performance. So in conclusion, athletic injuries can lead not just to chronic Alzheimer's or early dementia, but serious implications. We talked about the spine, we talked about concussions, about transporting the athlete, having him evaluated by a physician, and we talked about the basis of prevention and performance. So thank y'all for allowing me to talk.